Good morning everyone. Myself Dr. Amrita Aggarwal from Department of Oral Medicine and Radiology. Today I am going to discuss fibrous dysplasia. These are the contents: introduction, classification, fibrous dysplasia definition, etiology, clinical features, monostotic form, polyostotic form, histological features, radiographic features, treatment and prognosis, other forms of fibrous dysplasia, and conclusion. Introduction: fibroosseous lesions. Fibroosseous lesions, these are the lesions in which bone is replaced by the fibrous tissues. Lesions wherein bone is replaced by connective tissue fibers. The spongy bone is replaced by peculiar fibrous tissue, which may or may not show the presence of osteoid metaplasia. It results from the abnormality of development of bone forming mesenchyme. Fibrous dysplasia, it is a fibroosseous condition involving one or more bones of the cranial and extracranial skeleton, consisting of non-encapsulated lesions which have undergone localized change in normal bone metabolism and shows replacement of the normal cancellous fibrous tissues containing islands of metastatic bone. It is a non-hereditary disorder of unknown cause. Etiology. Etiology is classified into two. First is non-hereditary and second is caused by mutation or in GNAS1 gene. GNAS1 gene, it encodes a G protein which stimulates the overproduction of CAMP. Continuous activation of the G protein leads to the overproduction of CAMP in the affected tissues. Hyperfunction of affected endocrine organs, frequently giving rise to precocious puberty, hyperthyroidism, growth hormones, and cortisol overproduction. And increased proliferation of melanocytes, which results in cafe-au-lait pigmentation, results in large cafe-au-lait spots. CAMP also affect differentiation of osteoblast. Clinical features. Three diseases pattern are recognized in fibrous dysplasia. First is monostotic form, in which only single bone is affected. Second is polyostotic form, multiple bones are affected, and craniofacial form, in which cranial is affected. Monostotic form is the most common form. It accounts 70% of all cases, involves only one bone, and most often involves the jaws. Most common sites in order of affection are ribs, femur, tibia, maxilla, and mandible. Maxilla is more commonly involved than mandible, and more common area is premolar and molar region. Occurs in older age group. No sex predilection is seen. Lesions become static when skeletal growth stops, but these may become active in pregnant females or with the use of oral contraceptives. Often discovered as incidental radiographic finding, patient may complain of unilateral facial swelling or an enlarging deformity of alveolar process involving buccal and labial cortical plates. In mandible, it causes protuberant excrescence of inferior border of the mandible is seen. Teeth involved are either malaligned, tipped, or displaced in case of fibrous dysplasia. There is a presence of supernumerary teeth, which is commonly found in the midline of maxillae and mandibular premolar region. Teeth may affect eruption of normal teeth. Pain and pathological fractures are rare. If extensive craniofacial lesions have impinged on nerve foramina, neurological symptoms such as anosmia, loss of sense of smell, deafness, or blindness may develop. Polyostotic form, in which more than one bone is involved. It is seen as Jaffe's type and McCune's Albright syndrome and monomelic type. In Jaffe's type, it involves variable number of bones accompanied by pigmented lesions of skin or cafe-au-lait spots. McCune's Albright syndrome, it is a severe form involving nearly all the bones in the body accompanied by pigmented lesions of skin plus endocrinal disturbance of various types. Monomelic form involves only one extremity, and it is a very rare form of polyostotic form of fibrous dysplasia. This is a picture showing the cafe-au-lait spots. Jaffe's type, 20% to 30% of fibrous dysplasia is deafness type, usually found in the children and with less than 10 years of age. In this, there is expansion and deformity of jaws. Eruption pattern of teeth is disturbed because of loss of support of developing teeth. There is asymmetry of facial bones with ballooning of the jaws, which results in gross enlargement and deformity. Pain in involved limb, and there is chances of spontaneous fractures due to shepherd crook deformity. Structural integrity becomes weak. Bowing of weight bearing bones, curvature of femoral neck and proximal shaft increases. Shepherd crook deformity. This is a picture showing shepherd crook deformity. Serum alkaline phosphatase levels, which are usually within the normal levels, are sometimes elevated in this type of fibrous dysplasia. McCune's Albright syndrome, it is usually found in females, shows endocrinal disturbances like precocious puberty, goiter, hyperparathyroidism, Cushing syndrome and acromegaly. Secondary sexual characteristics such as pubic hair and axillary hair and development of breast are evident by age of 5 years. It may result in crippling deformities and fractures. Bone and skin lesions are usually unilateral, long bones and frequently affected. Expansion and deformity of jaws. Eruption pattern is disturbed due to loss of support of developing teeth. Asymmetry of facial bones with ballowing of the jaws. It results in the gross asymmetry, enlargement and deformity. Next one is craniofacial form of fibrous dysplasia. Here dysplasia extends to involve maxillary sinus, zygomatic process, floor of the orbit and sometimes base of skull. Results in severe facial deformity and malocclusion. Lesions may produce anosmia, that is loss of sense of smell, deafness and blindness with proptosis of affected eye. This is orange peel radiographic manifestations of fibrous dysplasia, in which orange peel appearance of fine dense trabeculae is seen. This is dense portion of fibrous dysplasia. What are the differential diagnoses of fibrous dysplasia? First is ossifying fibroma, Paget's diseases, osteosarcoma, cherubism and hyperparathyroidism. Treatment: conservative treatment to prevent deformity. Management requires a multidisciplinary approach in polyostotic form. Bisphosphonate therapy, for example zolentronic acid, alendronic acid, may help to improve function, decreases pain and lower the fracture risk in some patients. Surgery indicated for confirmatory biopsy, correction of deformity, prevention of pathologic fracture and eradication of symptomatic lesion. Second is cherubism. Synonym is familial fibrous dysplasia. It is rare inherited autosomal dominant disease that causes bilateral enlargement of jaws, giving the child a cherubic facial appearance. It is a familial multilocular cystic disease of jaws. It is composed of giant cell granuloma like tissue and doesn't form a bone matrix. The lesion regresses with age. Classification: it is classified into 3 grades, grade 1, grade 2 and grade 3. Clinical features includes: it develops in early childhood between 2 and 6 years of age and presents a signs that is painless firm bilateral enlargement of lower face. Enlargement of some mandibular lymph nodes may occur, but no systemic abnormalities are involved. Because children's faces are rather chubby, mild cases may go undetected until the second decade. Profound swelling of maxillae may result in stretching of skin of the cheeks, which depress lower eyelids, exposing a thin line sclera and causing eye raised to heaven appearance. Radiographic features: lesion is generally bilateral and often affects both the jaws. When it is present in only one jaw, mandible is the most common location. Epicenter is always in posterior aspect of jaws, in ramus of mandible or tuberosity of maxillae. Lesion grows in anterior direction and in severe cases can extend almost to midline. Periphery usually is well defined and in some instances it is corticated. Internal structure resembles that of central giant cell granuloma with fine granular bone and wispy trabeculae forming a prominent multilocular pattern. Expansion of cortical boundaries of maxillae and mandible by cherubism can result in severe enlargement of the jaws. Maxillary lesions enlarges into the maxillary sinuses. Because epicenter is posterior aspect of jaws, teeth are displaced in anterior direction and degree of displacement can be severe, and with some lesions the tooth buds are destroyed. This is the radiographic. Thank you.